particular.
Good.
Because, I mean, there's a number of things we want to hear and learn from Kerala, both about the epidemic response, but also continuity of services, managing regular services, issues with urban migrants. So there are a number of issues that we can listen to. And I was just thanking Sarah for being online on a Saturday afternoon with us.
Yes, indeed. Big thank you. Really appreciate it.
Sir, Dr. Yasmin is our representative here to India. So she's here with us today. And I think very keen to listen to the lesson from Kerala as well.
Indeed. Thank you. Thank you for making your time for us. Okay, so I'm going to go off camera and listen very intently.
Yes, we have 5 minutes to go
Okay.
because it starts at 3. So we're giving a bit more time for people to come online. And then we start.
Colleagues who have joined in, please click on the app link which is provided. This is for question and answers, and I'll be running a small poll in the beginning just to get us accustomed to this Slido. Please, if you don't see the link, do let me know. I'll again copy and paste it. It will automatically take you to the page. You'll see a couple of questions which would be already there by anonymous. You can type in your name, or what I'll do is I'll make one of the polls live so that you can answer those poll.
Ajay, Salima is asking to please share the link again.
Okay, I'll do that. Luigi.
Oh no, she says she got it. Sorry, forget it. No, io veramente devo restare zitto. Ajay, we give another 2 minutes and then we start, yeah?
Yes, please.
Just to be on the clock, and then we get going.
Colleagues, please join in on the Slido link. You'll see a poll there. It's asking, where are you tuning in from? You can type which city are you calling in from. We will take those inputs. Just wanted to see where all are we calling in from.
And sorry, before we get started, Ajay, do we have to show slides? And in such case, is it arranged or?
Sir, would you be sharing the slide, sir?
Shekhar, this question is to you.
No, I don't think so.
Okay.
Okay, let us see what arrangements work best.
I have, if I have to reply, I have to share a PDF. So how do I
Okay,
do
sir.
that?
Sir, you can share it with me. I'll or you can just share your screen.
I'm a bit skeptical about Zoom, so nevertheless, I will just send you a mail.
Maybe that is, yeah, the fastest way.
Could be.
Okay, let
I'll
us
just-
the email come to you, Ajay, and then I think we can
Yes.
open
In
the
the
session.
meantime, the intro happens. I'll just put that thing up.
Okay, yes, I think it's 3, so people are coming live.
Luigi,
I
if you can ask colleagues to join on the Slido, and that's where you can begin with. Colleagues, please join on the link which I have shared. If you don't see it, I'll paste it again. There's a poll live. It asks you, where are you joining from? Please type the name of your city so that we know how many people have joined in. This is for the question and answers. You can type in your questions once I'll remove the poll, and then you can write your name, or if you want to post it anonymously, that's also fine. We'll go through the presentation first, and then we'll take the Q&A from everybody, if that's all right.
Okay, shall we get started, Ajay?
Yes, please.
So good afternoon, everyone, again. And we are here. It's a Saturday afternoon, so thank you so much to everyone for making the time to join, and particularly to Dr. Kuriakose. I hope I'm giving justice to the pronunciation of your surname, sir. Who is joining us from Kerala, and particularly Dr. Kuriakose has been a member to the Kerala State Disaster Management Authorities since 2013, and has held the position of member secretary since 2016. This has, of course, involved a number of critical operations like emergency response to the floods in 2018 and 19, and in these days, a role of critical leadership in addressing the COVID-19 pandemic in the state. At UNICEF, sir, we are really trying to learn, to exchange, to fertilize good practices and lessons across our offices, which are located across 13 states of the country. So our teams really had expressed these requests in one of our many meetings to get to share lessons from various states, and in particular to hear how in Kerala, I mean, you were the first who had a case back at the end of January of COVID-19, but the state has taken a clear approach that so far has proven successful to manage the containment of the epidemic. So we really wanted to take this opportunity to hear from you about the experience in the state, what has been done, what has worked, what has not worked, perhaps. And in looking in that, we really look forward to learn your perspective and views, not only about the EU response to the epidemic, but also how in the state you have managed and what challenges you have faced in giving or maintaining a level of essential services for the population during the pandemic. So I would not want to spare any more time in my introduction. I really would like to thank you again for making the time for being with UNICEF today. Again, colleagues, if you have questions throughout the presentation, please do go on the chat box and look at this link to Slido, and you can type questions there, and then we will take all the questions towards the end of presentation. Ajay, I hope the PowerPoint has reached you.
I have the PDF of the documents which sir had shared with me. So
That's fine. Yeah, whatever formats. I think
I'm not actually doing a presentation because I think that's not appropriate to do in an elite audience. I will explain what we did, and I think it will be pretty much clear for everybody to know what we followed, the path we followed. I don't think that an illumination is required with a PPT to do that. Second thing is the PDF that I shared was specific reply to the question on what and how are we managing the Gulf returnees. So for international travelers and migrants, that government order is what is applicable. It's a guideline and SOP which SDMA had designed and issued as a notification.
okay. Perfect, sir. The floor is yours. We are very happy to listen to you as you tell us the story of how since January you have been managing this. Please, over to you.
Thank you, UNICEF, for organizing this. Some of you might have been there in the previous discussions that happened on this matter when the JNU organized such an event. I would urge everybody to mute their respective machines so that there is no ambient noise, and usually Zoom tends to have that catching up after a while. So when did we start? We actually started on 19th of January. That's when we really started with COVID, and that was when the state didn't know, the country didn't know that there is something called COVID. It was always called novel corona. On 19th of January, the epidemiologist or the public health expert within the State Disaster Management Authority kind of alerted us early in the morning saying that there is this spread of virus that's happening in China, and that it apparently seems to be creating problems in China in large numbers. So it was shared in the SDMA group. So we were discussing about it. And one of the things that I knew a priori was the presence of a lot of students from Kerala who were studying in China, particularly in the field of medicine. So we were a bit concerned with this spreading information that came from our public health expert. So we didn't want to take a chance. So we sent out a formal alert message to the state epidemiologist, or in fact, the additional director health who handles and liaisons with State Disaster Management Authority on statewide matters related to health. So we flagged this issue to her and suggested to her that January, February being the time that usually students from China return to Kerala, it is something that you need to be worried about, and that you have to have an attendance of what comes forth from China given this novel corona. And I would have to say that that was just an intuition that we had, and probably we were not thinking that it would come and land in Kerala the first, but we were sure that this was not going to end in China. So that was the resolution of the discussions that happened. And anyways, the email was sent, and on 23rd, the health department organized a meeting within themselves with the epidemiology, the public health group. Everybody came together and discussed and kind of alerted the state about the fact that there is a possibility that this disease would create problems not only for China but also for the rest of the country, and particularly for Kerala. So we have to be worried about the students who are from Kerala who are studying there and who might come back. And of course, there are a lot of people who frequent China from Kerala for various reasons. Now, this happened on 23rd. Then the landmark event happened on 2nd of February, when we internally raised a note within State Disaster Management Authority and placed it before the State Executive Committee, suggesting that COVID or novel corona has to be declared as a state-specific disaster. So that was 2nd of February. And this was because that we realized that if things go as bad as what is happening in China, we would need a lot of access to the Disaster Management Act, as well as taking steps which are extraordinary and will require a lot of funding to tackle the situation here. So this was anticipated in the month of February. And I must tell that when this was done in Kerala, it was initially looked upon as an overaction, and people were raising their eyebrows as to why this has to be a state-specific disaster. Nevertheless, the government of India eventually had to do it in the month of March. Things came to a situation where the whole scenario changed and it became a disaster. Now, 2nd of February, when we notified it, the tourism sector was very upset. Tourism sector was thriving, and that's one of the major cash earners for the state. So a lot of tourism industry felt that this was quite a bit overdue. So that notification also had ramifications across the world, where people looked at Kerala as if a possible COVID scenario would emerge there. And in the meantime, on 31st of January, we already had the first 3 cases who were basically students who returned from Wuhan. So that already kind of had spread across the world. And because of that, in between, we also decided that while we maintain the alert levels and the access to the Disaster Management Act in terms of executing in the field, we would denotify it as a disaster affected state. But instead, we will continue looking upon it as a very serious scenario. Subsequently, the situation further evolved, and by the end of February, I guess, we again decided that the state has to be notified as COVID affected, because then that changes a lot of perception of public in terms of how they look at the disaster in itself. So yeah, from the management side, that's when all this started. Since February, we started regularly holding the crisis management group. This is chaired by the chief secretary, and the crisis management group anyways exists before it. So they started meeting 2 days in a week. An honorable chief minister decided that he will personally review the scenario. So every second day, he also started taking review meetings. The frequency has come down. It's now 2 days in a week. So eventually, systems were put in place, task groups were formed, and different activities were triggered. The health department conducted massive school level training to start with, where school students were oriented through our captive education channel. We have a television channel run by the state government only for students. So in that channel, there was a series of training programs on what to do, what not to do in terms of COVID. And this process has started on. We started also pushing allied departments to work towards COVID crisis. Sometime in the month of early March, we decided to reduce the number of staff who were attending offices. But remember, at any of these instances, the numbers were pretty low in Kerala, but we were sure that this was the new normal, and it's better that we start early so that we get accustomed to this whole process earlier. Having said that, one day before the government of India declared a lockdown in the country, we also took a decision that the state had to be locked down, because that was what was identified as the way forward by the crisis management group. Then, of course, we inventorized every hospital, private, public, whatever. The SDMA has already a huge resource inventory. So this was shared with different departments. We came up with a contingency plan. It's called the COVID Frontline Treatment Centers. The plan was kind of scripted in the month of March. Starting from end of February, SDMA started running a SIR model with local information, kind of populating it with data which is very localized, and we came out with results. Every fortnight, the results were presented before the Chief Minister and the crisis management group, and anticipatory actions were activated in the districts based on these models. Subsequently, from the month of May, when we started getting good numbers, we also further fine-tuned the data and the model to fit to what was coming out. And yeah, we still continue to do that. So in-house in the State Disaster Management Authority, we have a team of epidemiologists, actually community medicine specialists from the Trivandrum Medical College posted, who works with our team to map it out and also project what scenarios we do expect. Accordingly, resource allocations were also made. In total, about 300 crores have been allocated, and we have, and for the surge, we anticipate the surge would be in August, and we cross correlate it with what comes out of Niti Aayog in trickles to see whether we go along with what is happening across the world. Having said that, there is a trigger mechanism that is also scheduled for starting off. As of now, we have 29 COVID frontline treatment centers, which are basically a ring of defense around the healthcare system, wherein the patients or the less ill are not directly sent to the hospitals, but are sent to the COVID frontline treatment centers, and they're taken care there. They are run by the local self-government. And I must tell you that the biggest boon of the state is that we have a very robust and grassroots level local self-government mechanism, which kind of is taking up the responsibility of identifying these centers, readying it for quarantining activities, and taking it up further in terms of facilitating appropriate care for people who are quarantined there. And this quarantine is not suspected cases, but are positive cases. So this is how the systems are ready. And when the state epidemiology team decides to trigger, there is an expert committee here which works and looks at all these things, which is chaired by Dr. V. Iqbal, who was former principal of Trivandrum Medical College, a renowned professor in medicine. So that expert committee triggers and tells us when to start what, and the resources and systems are kept mobilized for those aspects. Now, in order to ensure that fatigue don't set in, there are also schemes implemented right from the beginning to ensure that the same team doesn't work round the clock, of course, except critical facilities like Disaster Management Authority, the Health Directorate, the Corona control centers and stuff like that, where people, institutional memory is very important, and hence you can't just bring in people from anywhere and run them. So other than that, it's pretty much in control now. As you can see, the community, there's hardly any community spread. Contacts are traced to the last mile. We have an integrated platform where this is done. Every day, State Disaster Management Authority notifies new containment zones and deletes containment zones. There is a lead protocol for that. We also map every individual up to the last mile. This again we started in the month of February when the first 3 cases came. So we have a huge database which indicates even the behavior of these individuals as to data captured through online interviews with them, telephonic interviews with them, as to understand how they got it and who all they transmitted it to, what was their behavior within the the hospital, if they were in the hospital, or within the CFTC, if they were in the CFTC. So this process is running for quite some time now, and hence we have very local control, and that is probably the reason, and that's what I said, the boon of the state is the local self-governments, and because of that, the mechanism is able to cater to every individual who is in home quarantine or institutional quarantine or a positive patient. So yeah, that's the mechanism that was made. Every airport was being scanned and kind of looked at right from end of February very carefully. So we basically got the advantage of being an early bird. That's what I would say. So January 19th, we began when the rest of the country was still contemplating it. And yeah, so whatever you see are basically the results of two major things that I ascribe to, and I have been always telling this everywhere. One is the historic legacy that Kerala has had in terms of its educational levels, to very strong healthcare network, and both of them Umbrella and the local self-government mechanism, which is very robust at the grassroots level. So governmental mechanisms basically facilitate.
Dr. Shekhar,
Yeah.
I think your voice is breaking and there's an echo in the background. Is it possible for you to use a headset on a mic or something?
I will give you a non echoey as what is possible.
Hello, Kaushik. Sir, can you log out and log in again? Probably that will clear the. This is
Ajay,
now
your
good.
brain has gone.
But your voice is also echoing, Ajay.
Yes.
Okay.
I'll leave and come back.
I think if the problem is not at your end, Dr. Shekhar.
It
Now
seems
it's better.
better now. Let's check.
It's better now.
It's better now. Yeah.
You can continue, Dr. Shekhar. It's better now.
Not sure if it dropped or.
I think he was logging out and then coming back.
Yes.
Let's wait for a minute and
We hope.
questions are coming. Yes. I think Sir is back. Let's give the floor back to him. Can you hear us?
Yeah.
Okay, fine. Yes, perfect. Thank you.
So, yes, what I was telling is that we were, one, lucky to be an early bird. Two, our healthcare mechanism, our education levels, and both umbrellaed under the local self-government mechanism proved to be the boon. So, yes, that's what we have done. Of course, now the state economic systems have been realigned to suit to the conditions that are prevailing. You know that Kerala is not a very rich state in terms of cash flow. So we have limitations there, and that is being handled. In the meantime, we also have started a lot of livelihood support mechanisms through various possibilities. Our Chief Minister's Distress Relief Fund is amply being funded. A lot of good people across the world is contributing to it. So we are able to actually try and conceptualize certain other activities, which is in the making. So yeah, what would I say? Yes, we have tried to do what is best possible in the state, given the levels of education and healthcare network that we have, which is fairly pretty good as compared to the national averages. So yeah, I don't want to promote an euphoria of Kerala model or anything here, but I would like to say that if anybody asks me, what should you do to tackle COVID or anything of this sort, I would just humbly request you invest in education, invest in healthcare, and strengthen your local self-governments. That's what you should do. So yeah, that's what I want to tell now. So if you have any questions, I'll of course answer. And I do see Kaushik asked me what kind of digital innovations were used. Oh, quite a lot. In February, we understood that this is a disease which would spread in a manner where interaction rates between persons would be very crucial, a parameter which would determine where and how it will spread. So one of the very first things that we did was to create a platform wherein every patient identified, every positive case identified was logged in, and corresponding primary, secondary contacts and those under surveillance were registered. So we were able to actually establish and create a network which shows how every patient or every positive case was transmitting the disease. This information was very crucial for us to start modeling in the SIR environment, because this is very essential and information at the grassroots level. So determining the R note was a very crucial requirement, and that requirement was met because we had a digital platform where at the lowest level, from the PHC, CHC, the local junior health inspectors and IT volunteers were feeding in data to enable us to take judgments of where the hotspots would be, where would be the containment, and how we do it. I think I can show you some maps on the screen here in the EOC, where you would know what is happening. Ravi, can you just put on the map of the positive cases of yesterday that we had prepared? The whole map. Yeah. So I'll just take you to the screen where you can actually see it. I hope you can see it. So just hold on. These are the positive cases live as of yesterday. Can you see?
Yes.
Yes.
So yes, so that's now you can zoom in into that, please. So you see, this is done every day. And now if you can show the containment zones that we do. Yesterday's is there, no? Yeah, so here are the containment zones. So basically, the containment zones are revisited every day, and the epidemic potential there is assessed, and accordingly, the maps are released in public domain as well as to district collectors. So yeah, this actually is the basis of how containment happens in the field. And this is again something that we started in the month of March, early March. So, and we also, because monsoon is on our skies now, and we actually planned and created an orange book, which we already had been publishing. This year we amended it with respect to what COVID would also addedly bring to it. And depending on that, we also determined that we will have 4 kinds of relief camps in the field. So it's not anymore one kind, it's 4 kinds. The first one is for general public, 2 is for anybody who is greater than 60 years, who would have to be relocated into a camp. The third is for home quarantined people in the local self-government area. And the fourth are people who are already having some suspected symptoms of COVID when they come to the camps. So 4 kinds to ensure that we try and contain the disease as much as possible. And the CAM guidelines have been revised with about 106 different parameters to be observed in the field. So yeah, we are now in kind of mutually excluding all these four, and also keep apart a large asset inventory for any surge that we would expect in the month of August. So that's what we are planning. That's what is being done in the state here. We also have a lot of different what do you say, apps which we use for capturing data. For example, through the checkpost, out of the checkpost, people coming from abroad. It's called COVID-19 Jagrata. It's a platform that we created where an integrated view of things are available. But of course, only for officials. So if you look from outside, you would only see a portal for registration, but you will not see the larger picture. The larger picture is available in Kerala Battles COVID. That's a platform that we have created for this. I will share that link here, so you know you will be able to find a lot of information on that. Right from the beginning, the government orders, everything is available there. Lack of safety for healthcare workers. Well, this is we have had been constrained as in the rest of the country with a certain safety gear in the beginning days, but now we are pretty sound in terms of availability of PPE kits, in terms of swab kits, in terms of RNA DNA testing facilities, PCR machines. Antibody tests are also ongoing. So this now things are pretty sound. If you had asked me the same question sometime in the month of March or April, yes, we had difficulties that we had to work really hard to tackle. Stigma. Initially, in the beginning, people thought that this was very difficult and that things were very bad. But I don't think that there is any stigma anymore in the society, because people now understood that this is nothing graver than a fever for a healthy human being unless comorbidity exists. Nipah lessons, yes, Nipah lessons obviously help, but you must realize that having faced Nipah or faced anything, it would have been possible if we didn't have the educational capacity that we had and the healthcare capacities that we had. So yes, Nipah was more like a mock drill towards this, but Nipah was also tackled well, and COVID was also tackled, or is being tackled pretty in a decent manner, for the reason that the healthcare mechanism of the state is sound. The investments that all the governments in the state had continuously made in healthcare and education are the two shoulders on which we stand high. So yeah, that's what I would answer about it. And intrastate and interstate migrants, we had about 3.6 lakh migrants here in Kerala. Now, as on today, I think it is only 2 lakh who are remaining. But interestingly, a lot of migrant laborers who kind of hurried back home have started coming back. So every train that is coming back from Delhi or wherever is bringing in a lot of these people back to Kerala. Sarabjit is posting Corona Safe Network. Yeah, Corona Safe Network is one volunteer community initiative. That's fine. I mean, there are two things that are very interesting from Corona Safe Network that we are trying to scale up to the state level, which is one, their ambulance network information system, and the second is their hospital information network system, which was very well working in Ernakulam with about 88 hospitals. So we'll try to scale it up for the rest of the state. If it let's see how good it would work. It's yet to start, for that matter, at a state level. How important has modeling been in supporting decision making at all levels of administration? In Kerala, I told you, we started in the month of February. So every fortnight, we presented before Honorable Chief Minister and the Crisis Management Group, which is basically chaired by the Chief Secretary, and the decisions and the search plans, the contingency plan for COVID is based on that. So we look at those numbers because, one thing we all have to realize in this disease is that we know that our knowledge about who has this disease is limited as compared to what we know. So if you know that the unknown is larger and the known is lesser, then it is always good to work with the unknown as a big number and work with it to ensure that you don't you are not taken on surprise. So that's what we do. Spirit of volunteerism, of course. Kerala has a directorate of volunteerism, which we started after 2018 floods. Honorable Chief Minister took personal interest in doing that. And we have 3.5 lakh volunteers registered therein. Out of that, on any given day, we have about 70,000 people working as volunteers. We have civil defense. The entire state is notified as civil defense. Probably in the whole country, this is the only state which has all its districts notified as civil defense districts. Therein, 7,000 trained volunteers are available. We also have Aapta Mitra volunteers, which is a project that NDMA funded us in Kottayam. 200 volunteers with all kinds of response equipment. So all these people worked very closely with the local self-governments. And further, in 2019, early 19 and early 2020, we did what was called local self-government disaster management plan. So all the LSGs in Kerala now have their own disaster management plans. And as part of the LSG DM plan, we also have 4 kinds of emergency response teams, wherein local volunteers are enlisted by the local self-government and they work very closely with LSGs. Of course, this has varying levels. When it was complete lockdown, we had the maximum utilization of these people. But when the doors started opening up, a lot of these people had to also go for their own bread. So yes, it keeps going up and down depending on the occupational practices of the people. But nevertheless, there is consistently a good number of volunteers who continue to work both for the management from the EOC side and further also as foot soldiers. And yeah, that is also very inherent in the society of Kerala.
Dr. Shekhar, just a few questions which have been voted up on the Slido. One question is, how are RMNCH service continuity being tracked during COVID-19 pandemic? The maternal, newborn, child health kind of things, how are they being tracked?
See, what we have to realize is this, that's where, I mean, it might be a surprising question for a lot of people around here in Kerala, for the reason that here it happens normally. We have ASHA workers, we have Arogya Sena. Arogya Sena is yet another volunteer team which works very closely and within the health department. So all this natural issues which are even otherwise there because of our human evolution is taken care by that mechanism intact. That's why I told in the beginning that our healthcare mechanism is still intact and unaffected by COVID. The reason being, we created a ring of defense around it. There is a large ring of defense around the main healthcare mainstay. Our PHCs are not overwhelmed. Our hospitals are not overwhelmed. As such, even facilities are not overwhelmed. The reason being, they are ring fenced through a makeshift, arrangement, what we call as Corona frontline treatment centers. So people are not directly pushed to the hospitals. People don't have to go there in the first instance, not even to the PHC. If they are suspecting COVID, they are asked to go to this particular center, which is designated. There are 14 districts in the state. We have 29 hospitals and 29 COVID CFTCs associated to each one of these hospitals. So the hospitals takes care of these CFTCs. So they are linked like that. And because of that, our normal healthcare mechanism is not affected. That's how it is taken care. So we don't have to really go overboard to do it. Yes, of course, there is one instance, for example, I'll explain where we face problems. We had issues when we were on complete lockdown. Our persons with hearing impairment had to replace the batteries of their cochlear implants. Our Apta Mitra volunteers and our Sanadham volunteers came together through the Disability Inclusive DRR program of SDMA. And batteries were picked up from districts where it was available, like Cochin, and transported all the way to Wayanad and Idiki, furthest distances, to provide for these persons with disabilities. So you see, volunteerism again proving its mettle there. So yeah, that question of how this issues of reproduction, reproductive issues, maternal issues are tackled in the state. These are even otherwise tackled, and we are not overwhelmed. So our healthcare mechanism has not been troubled at all yet by this COVID, other than intense planning and a lot of constant monitoring. So
Uh,
yes, doctors and nurses do have a degree of fatigue because of it, but that is only in places where there is persons who have undergone treatment.
Thank you very much. The next question again is, how is home isolation, contact tracing, and lab surveillance data triangulated?
There is a single platform I told you. It's called COVID-19 Jagrada. This was developed by the eHealth in close association with NIC. So in there, all this data come together. At SDMA, we look at positive cases, primary contacts, and secondary contact numbers on a daily basis, including to the last mile of looking at their addresses and plotting them onto a geospatial platform, and then visualizing it or providing a visualization of it to the health department to understand where they are spread, and utilizing this information for deciding where the containment zones are. So this process is happening for long. The lab data is actually gathered right from the lab onto this platform. So it's not that somebody has to physically transfer this kind of results and all that, but it is actually fed into COVID Jagrada. It is not available for anybody and everybody to see. There are only selected offices where there is a visibility of this data.
Thank you very much, sir. Again, there's a question which is pertinent to other urbanized states. How was private sector roped in? Were professional healthcare associations engaged in COVID response, and what was their contribution?
Yeah, I do see that question. Yes, private healthcare, right from the beginning, the decision was that they would be roped in if there is a surge. And when we anticipate a surge sometime in August, the private sector has already been roped in, and a round of discussions have gone with them at the level of the health minister herself. She has taken meetings with them and have decided that there will be packages for COVID treatment through the private sector. So wherever the state government decides to send a particular person to a private hospital, only for those people where the state government has taken that decision that don't have that capacity now, this many people need to go to private, those people, the state government will take care also of the expenses of their treatment. That's what I'm made to understand from the last discussions that we had on it. Professional associations, IMA is very closely involved with us. IMA officials are probably somewhere here around. In my office itself, there are a couple of them working with us. Then with respect to the government medical officers association, there's a association of the medical doctors themselves within the government mechanism. So there again, they are also working very closely with the government. And as such, I mean, in the healthcare sector in Kerala, there is not much of confusion with respect to who does what. IMA, whenever had to voice out their concerns, they do voice out, and wherever the criticisms or opinions have been of merit, the state government has looked at it, and Honorable Chief Minister himself has had, taken notice of those and have discussed in different meetings. So there is absolutely no contradiction happening around here in terms of what we do and what shouldn't be done.
Again,
But your
sir,
question on package on livelihood support,
yes, sir.
interesting. See, I hope you are aware that in Kerala we have a lot of already a lot of livelihood support mechanisms. The first thing that we did in the month of March after the lockdown was announced was that we gave out a huge 1 month ration of various items to every PDS subscriber in the state. And in Kerala, out of the 98 lakh families, 86 lakh families are registered under PDS. Now, whoever was not in PDS, even they were made to go and gather provisions for which could last for a month from these shops, from the PDS network. Secondly, in the month of in the month of May, we gave a second round of assistance in terms of provisions for all these families, which were basically kits, of different kinds of materials, which included pulses and little spices and all that. So there were 2 times that enough provisions were given to households so that there is no real crisis. And this was not just for people who were in PDS. Initially, it was given to PDS subscribers and then thereafter extended to people who didn't have. Now, every pending social welfare scheme, the pensions of the social welfare schemes were given off in the month of April, every single one. And then there were a little number of about 1.2 lakh families, I guess, who were falling outside any social assistance from any of the welfare schemes of the government. They were pinpointed and identified by the local self-governments, and they were given another cash assistance of, if I remember correctly, 1,000 rupees. So there was another mechanism which was put in place. This was also extended to fishermen and a lot of different walks of life. So this again, I must tell that the social welfare network of Kerala is a long-standing one. It has a lot of legacy in welfare boards and welfare mechanisms and cooperatives. So this cooperative mechanisms have again proven good. It proved good in the times of floods, and it is proving again very good because the cooperative networks are helping people out with their own funds. The cooperative networks are not taking money from the government. They are making money themselves and is parting with that money to help the people who are within the network. So yeah, that's how it works.
Sir, colleagues, we are trying to ask all the questions, and we have a choice of voting for the questions which are already there. And that's something which the questions move up as anybody poses votes for a particular question which is already there. Sir, on to next question. What was the role of State Disaster Management Authority versus the health, and what kind of budgets were managed? How is disaster management preparing for the flood season?
I think I mentioned about this early. Uh, the health department is the one which leads it. SDMA is not an entity which is independent of health department. If you look at the State Disaster Management Authority of Kerala, the State Executive Committee has the Health Secretary as one of the 5 members. It's since 2007. And when in the month of February, we notified COVID as a state specific disaster, we also decided that the incident commander of this whole episode will be the health secretary himself. So we are not two institutions, we are one institution. And that's the most important part of it, to work as one. So here we don't have any difference between what they do and what we do. Of course, there are certain budgetary allocations that we manage. That's particularly the State Disaster Response Fund, Government of India. I told you when we notified it as state-specific calamity, then itself we started utilizing that money for the management of COVID. So as and when the health department comes forward and asks for funds to facilitate their and augment their capacities, we have provided it. To the district collectors, we provide funds for migrant management and COVID quarantine center management, which in turn goes down to the local self-governments from the districts, so that the local self-governments are able to run these institutions without having to burden themselves on their own budgets. So yeah, that's happening pretty sound across for quite a long time. We have not found this difference between health and SDMA or something of that sort. Right from the beginning, as I told you, we were doing these maps and analytics. The medical college, the Directorate of Medical Education posted 2 associate professors and a team of postgraduates from Trivandrum Medical College to SDMA, because SDMA requisitioned their services, and they are posted here, and they work with the team of SDMA in mapping, in modeling, and bringing out results. So as I told you, SDMA works as SDMA, which encompasses health department, and the health secretary leads the show, and we follow suit. We whatever he asks us to help him on, we help him. Whatever is required from us, he demands and he takes over and uses. So there is no difference in what health does and what we does. It's one and the same.
Sir,
Yeah.
the next question, which got the maximum votes, is: are you addressing the current resurgence in cases any differently than before, and any particular reason for resurgence?
In Kerala, the resurgence of numbers are primarily because of the return migrants and our people who have come back from across the world. As you know, Kerala has a lot of people living abroad. So when they started coming in, many of them would have contracted it in the planes, or some of them came with the virus. And that is the numbers that you see around. But if you really drill down to the data, every day in the health bulletin, you will also see how many of them were affected through local transmission. That is given as a separate number. Yesterday it was 6. Today's I'm not supposed to reveal, so wait for our Honorable Chief Minister's messages in the evening. Day before yesterday it was 2. So that's how local transmission is. So that's actually good, because then we are able to identify and lock down potential areas of spread, and local transmission is coming down. But there are also strange events or super spreaders in double quotes. We Yesterday we had a case of an auto rickshaw driver turning positive in Trivandrum city, which is a very strange one. Hence, a part of Trivandrum city is locked down now. I've notified it as contingency, the containment zone. Then there was a similar case in Kannur corporation limits, in the city corporation limits, where a particular person from the market had contracted it and became kind of super spreader. So it's not that the spread is confirmed, but all his primary and secondary contacts are under surveillance. So because their numbers are high, we have decided that we contain those areas also. So yeah, um, that's the way forward. I think we have to go down, drill down to streets, to buildings. Some of our containments are one house and adjoining houses. Some places the containment is one whole building. Some places it's streets. So deciding on that optimally and putting every district administration within the same framework is what we do from State Disaster Management Authority. And our district disaster management authorities already have a mechanism, which had a mechanism in place prior, so that mechanism is still working. We have two control rooms now, one for floods and one for COVID in every district. So they are differently managed with two teams of IRS in place up to Kali. One IRS team manages COVID, the other IRS team manages floods.
Sir, thanks. Again, can I just request you to reconnect? Your voices again started breaking. Or if you could reconnect, the next question I'll share immediately after that, sir.
Ajay sir, it's fine, I suppose.
Sorry, sir,
So
for the
and
inconvenience. You are again live. This is an act we're trying to work around. So the next question is from Uma Mahadevan, and she asked steps taken to treat critically ill patients like cardiac kidney patients who are detected with COVID positive during their treatment in private hospitals.
Ma'am, that's quite a heavily loaded healthcare question. If you want, I'll call the associate professor who's around, would be able to probably answer that. I'm not a health expert, so I can't tell you
Okay.
how they are addressing that within the PPE kits and within the ICUs. But I can obviously tell you there has had been sincere efforts. We were successful in treating and curing patients of 80 plus. And if you look at the number of people who have died in Kerala, they're pretty low. And if you look at the patients themselves, most of them are with COVID, except for one case which is now actually a bit of suspected problem. Somebody's ambulance is coming through. Yeah.
I
So
muted it.
yes. So what happens is one case yesterday we had of an excise driver, an excise department driver, who was a in-service officer. Unfortunately, that gentleman was only 28 and he apparently didn't have any other disease. He was a healthy man, it seems, but he has died. So that's being investigated. But otherwise, as far as I am aware, because I look at the numbers and the data and all that, I have seen that people with comorbidity are recovered on a daily basis in large numbers. Of course, we would expect, and that is what we also projected to the government way back in March, saying that people with comorbidity, which runs to about roughly about 45 lakh people, are to be the ones who are to be put under reverse quarantine. And a huge campaign was unleashed in the state, wherein people of the age group of greater than 60 were asked to stay indoors. Like my mother, she doesn't go out of her house. She's like just there. She says, no, I'm not supposed to go out. So that has sunk into the minds of people who are elderly. Of course, the Pensioners Association initially came up and told it's very difficult to stay indoors. We want to be living active and all that. But then at the end of the day, they also realized, I believe, that it was only for their good. Now, when the unlock has started, we have started seeing a lot of interactions. But luckily, social or contact spreading cases are very few in number. So unless that exceeds a certain threshold, we don't see that there is anything that we need to be worried about or alarmed about. But then in the public domain, we do tell everybody that the situation is not so great, so that everybody continues to observe utmost and strict measures for ensuring lesser interaction rate.
Thanks, sir. Again, the next question, which is anonymous, is where did the state put more stress on? Awareness, surveillance, contact tracing, community isolation, quarantine, or hospitals, beds, oxygen, ventilators, training of doctors?
The stress right from the beginning was to build awareness. Rest of it, as you know, in Kerala, uh, pretty much sound systems are in place. The when the awareness was built, I told you the awareness building started with school students. We started with school students. Rounds and rounds of training in schools through our school platforms. You know this Victor's channel which we have, and of course doctors, their training, not just doctors, you know, the paramedical staff and the allied medical staff, you know, people who are like asha workers or arogya sena workers, people who are volunteers or more or less volunteers but then are able to support in building social awareness and creating a watch and ward network in the grassroots level. Our anganwadi teachers, they were all basically given awareness, and that awareness is the most important part. You know, it's not about just giving out a lot of material into public domain and telling that here is awareness material, pick it up. That's where I told, no, the investments that were made in the past is what is proving or materializing now for the state. The education levels of the society, the healthcare network of the state, this cannot be built overnight. You can't have you can have 100 ventilators or 1 million ventilators created, but if your society doesn't know and your systems don't have the capacity to operate with that level of certainty, then there is no point in having these mechanisms. So it is basically a very consistent and closely monitored initiative of our fathers and forefathers. And from their time onwards till even today, our great leadership, both at the state level and at the grassroots level, which has proven good. So awareness obviously is where we invested a lot of energy and time on. Uh, don't you see our honorable chief minister going out and telling every little nitty gritty on a daily basis? That builds awareness. The direct connect that he has with the public. If he says don't do this, the large majority just takes it on because they realize that this is being told by the government. So it would not happen if any other institution would have just taken it up and have tried. It could have only been done by our honorable chief minister because that position commands the respect, and that respect goes down up to the last mile. So we were able to build that awareness up to the last mile. You go to the remotest part of the state, you will hear people talking about COVID and people wearing masks and people talking about all kinds of measures required. Of course, there are 101 different opinions about how it should be tackled, but then some of them are logical, some of them comes all the way up to our chief minister, and he presents it and he talks about it in the crisis management group, wherein he says that, no, I've got this information. What is the reaction of the experts in here? So, yeah,
Sir,
aware.
thank you. Awareness is something which we understand is a game changer, and it's a consistent effort which will pay out more. Sir, we are at 4 o'clock. If you can take a few more questions, then we can put them to you, sir. Is that all right, sir?
Yeah, no problem. One thing I have to acknowledge here, you know, when we started off with this whole awareness program, as such, the systems were also learning how to tackle it, and where do you find money for doing this and that. And that's when UNICEF came and helped us with a good cash through. And you know what happened with that money? In many districts, they brought in one or two experts from the local area and also created huge numbers of awareness material, very local. You know, it's not done at the state level, but every collectorate made their own awareness material and distributed. So it was customized to the local language, of course, they all speak Malayalam, but then Malayalam is spoken in multiple uh, tones and modulations across. So this localization was very helpful, and that's where the collectors invested even the money that UNICEF paid us towards this COVID crisis. Honorable Chief Minister was very appreciative of that, and he spoke about it in public um, when he came to know about this.
Sir, we are really very thankful for you to share this, and this goes on to prove that we are there to support the state governments in the endeavors to tackle this pandemic. Sir, the next question is, what was the strategy, or what is the strategy for COVID response in urban slums?
Slums in Kerala are very different. I think we don't have many skid rows. We don't have that kind of slums which are very difficult and hugely congested. Of course, there are, but if you look at the number of cases or the incidence of COVID in such places, there's hardly any. We have not heard of one instance where uh, COVID is reported from Trivandrum's two major slums or three major slums around. Uh, the slum housing plan in Kerala was actually originally designed by none other than Laurie Baker, and then continued and carried forward by a number of his disciples in the state. And many of these slums over time have reinvented themselves with better housing, not great housing, but better housing. So, yeah, it's surprising that we don't have any cases so far reported from any slums. We have to watch and see what happens with the auto rickshaw driver who turned positive yesterday in Landfill, because that's where probably some spread has occurred for the first time. We are also waiting to know where all he traveled and what all he did. And then we will realize in the next 1 or 2 days after testing all his primary contacts.
Sir, any evidence of how COVID is affecting the children in your state? The evidence, how are they coping? What systems are there
I
focused
can talk
on?
from I can talk from my own experience. I have a 10-year-old and a 3-year-old at home who stayed indoors for literally since the month of from the beginning of March till last week. They have had not gone out of the house, to that extent, not into our courtyard even, and our garden even. So yes, the children were confined at homes. They were very keen. My 10-year-old was very keen to listen to Chief Minister every day. And in the evening around 10 o'clock, 11 o'clock, when I reach home, she would be awake asking me questions about how many patients were there. And she would relook at what Chief Minister told from her diary, saying that Chief Minister told so much. What are your numbers? And then she would be examining those numbers. So COVID, this gives me the lesson that COVID as a disease has sunk into the minds of children, and they fear it as if that it is a demon. Now, when I started talking further to my daughter about what she thinks of this disease, she was very unhappy with the fact that she was confined from going out and playing with her friends. And the worst part was that she was missing school. While the schools have reopened over the digital platform, children have not anymore, or children, I mean, we all were children at some point of time, and we would realize that having our friends around and playing with them and bullying each of them around isn't something that you can do through internet, right? So yes, it has taken a toll, and this was seen at some point of time in the month of May, when we pointed out this matter in writing to Honorable Chief Minister, saying that he has to address children. So he one day dedicated his evening address only to children, telling them that they are the future of the state and that they have to stand high. So that evening, when I went home and spoke to my daughter, she was very pleased to know that Chief Minister was concerned of her, concerned of children around. So this is how children are connecting. And what I realize is that while as of now we may have to continue with a lot of online educational systems, it cannot be replacement to contact learning. So because it really affects children in terms of their societal formation aspects. We also have, through the education department, a lot of entertainment programs designed and delivered through Victor's channel and otherwise for children. But I think at the end of the day, children have had a trauma, and that trauma is probably going to stay for a while, and we all have to work towards nullifying it in the shortest possible time by somehow reopening our schools where the contact learning re-begins. Initially, children were thinking that it was happy times. They could spend at home, uh, do whatever nonsense that they wanted to do all the mischiefs. But after 1 month, they all realized that that is not what they want. They want to go back to school. So children have also started using WhatsApp. I see that my daughter has some 2 groups with all her peers and friends talking in that WhatsApp group about what they do every day, which is not really great for children of that age. But at the end of the day, that's the only way that they are able to socialize as of now. So that's something that we have to crack. We will do it. We will all have to do it. We'll do it.
Sir, I'm sure you did not teach her to use WhatsApp, and the environment
Nobody
made
has to.
made them
Nobody has
take
to.
on those steps. And yes, that's
Nobody
something
has to. They are
children are
self-learning.
finding their own coping mechanisms. And there used to be a time when we used to say not much screen time, but now the necessity is screen time. Schools are happening on that, the movies, everything is on that. So that is going to be another challenge, and new challenges coming on there. So the next question is, you have addressed it partially, is there is an evidence that many health workers and the people who are engaged in COVID fight are going through fatigue, stress, and stigma, and lack of safety for health workers. You have addressed partially. How did you tackle these issues in the state in terms of fatigue and psychosocial support?
Fatigue definitely has set in, and at many places, because of that, we had to also rope in staff from different departments other than the health in itself. So yes, fatigue is a reality, and we have to find ways of tackling it. And the way that we found solutions for it, the critical healthcare workers are contained. I must tell you that they, right from the beginning, have had been given this 14-day cycle. So they go on duty on 14 days, and then 14 days they go on quarantine if they are in the COVID hospitals. So that mechanism of 50% work sharing is very well in place in the healthcare mechanism. But when you talk about peripheral surveillance officers, if you look at ASHA workers, if you look at Arogya Sena workers, they all have been working extensively from the beginning. And it's only on their shoulders that we all stand high. So those people, the fatigue, to reduce the fatigue at some point of time, early last month, Honorable Chief Minister decided that staff from other departments would also supplement. So for certain awareness campaigns, certain activities, school teachers were also utilized. Staff from other departments were opted into replacing certain activities which were continuously being done by a certain set of people. But of course, safety as such, I told you, on initial days we had problems. We didn't have enough supplies. Kerala is a consumer state. We are at the fag end of the country. So getting any supplies from anywhere was very difficult for us. But now we are in a very good position where we have enough supplies, sufficient PPEs are managed. I think on any given day, more than 100,000 PPE kits are readily available. So this is actually a process. A supply chain has been formed. We also have one company which has started making PPE locally. This happened a couple of months back. You all would have heard about Keytex, this very famous company in Kerala. It's again a cooperative. It started as a cooperative. So they are also now making a kind of PPE which is available. So yeah, initiatives are all on there. But fatigue is something that we will have to live with and ensure that we challenge the fatigue and live above it. So far, so good. It's happening. But as I told you in the beginning, I don't want to say that yeah we are all proof to fatigue. You know, we are not. We are like any other state, also having problems related to fatigue, but then not in very bad terms as yet.
Thank you, sir. We'll now open for 2 live questions. Slido has been a tremendous help for the organizing the questions. Anybody wants to ask the question live, a couple of them, and then we'll move on to closing this session. Anybody wants to come in with a question, please?
Jay, can I ask one question?
Yes,
Sarabjit?
yeah, Sarabjit, please go ahead.
Okay. So first of all, welcome. And Shekhar is from my tribe. So, sir, thank you so much for giving your time. One question I had, I mean, illuminate us a little more on how interdepartmental coordination has improved during COVID. And is it something significantly different from what we saw in 2018 during the floods, or any other sort of reflections on how departments are collaborating and cooperating?
See, it is something that is indispensable in this kind of a fight. In 2018 also, you would have noticed, you were here, you would have noticed that a lot of departments works together, because at the end of the day, at the last mile, it is the local self-government that works. So within the local self-government, this departmental differences actually gets nullified. But there are things that departments have to do. In this classic case of COVID, our crisis management committee in the state has all the secretaries attending, and the major responding HODs also attending. So which implies that the decisions made there gets becoming binding on them, and they all act. And our previous chief secretary and the present chief secretary have had been keeping that tightrope and ensuring that they all work in tandem. Of course, when it comes to major trans-departmental SOPs, like for example, how containment zones are defined, or how SOPs for people coming from abroad are to be issued, those administrative SOPs are issued from the State Disaster Management Authority, but after taking a consensus of all the departments in the crisis management group. At the district level, our DDMAs were working even otherwise. Even in 2018 also, they were meeting very regularly. That continues. So as such, we haven't found any problems in terms of interdepartmental coordination. Wherever there had been issues, we were able to step in and solve it. But by and large, everybody has understood that this is one integrated action, and it cannot be segregated and separated into this department or that department, because at the end of the day, it's just the government and the public around. So yeah, we have not found any issues in COVID response, at least in terms of how departments works between their compartments.
Thanks, Abhijit. Thanks, sir, for answering. Vandana, you wanted to ask a question?
Sir, thank you so much, Sekhar sir, for this very interactive session and wonderful guidance from Kerala. Just wanted to understand, when you spoke about the private sector regulation, how did you manage to control the pricing in the private sector, specifically PPE, the lab tests, and treatment packages?
Madam, we, as such, there are only 2 private labs where private testing of COVID is permitted. And those labs, only a handful of people go there, and the labs are also reporting it back to the government. Right from the beginning, these labs themselves came to the health department and told that we will only charge so much. Now, in terms of the private sector involvement in terms of treating COVID patients, I told you we still didn't have a requirement to do that. So as you speak today, we don't have anybody who's there in a private treatment except one case where he wanted to go to a private establishment and get treatment, and that he was wealthy enough to afford it. So he didn't ask any particular support from the government to do that. But when Honorable, I told you, Honorable Health Minister took a meeting with all this private, healthcare providing services. There are networks here in Kerala. They have coalition systems and all that. So she took a meeting last week also with them. We were all briefed about it in the meeting of Honorable Chief Minister. They all expressed interest in being part of the system. They said they are willing to help. Their only concern was with respect to the amount that has to be charged for treatment, and the government has told that whatever the package is set by Government of India, they should accept it. By far, nobody has really objected. We have already taken over some hospitals as CFTCs or where positive patients are treated, and some closed down hospitals were also taken over by the state to run. There's a whole medical college which we have taken over. It's a private medical college which was in distress. The state took over, and we are using it as a COVID hospital in itself. So there, the expenses related to electricity, water, supplies, all that is met by the state.
Thank you
so
very
much.
much.
Thank you, sir.
Any other questions, or we would otherwise close? Hari Balaji, you wanted to ask a question?
Ajay,
Yes.
I'm noticing we have taken way more time than what we had agreed. So maybe
last question,
if there is a
Luigi.
last one, let it please be the last.
Okay.
We are probably going well beyond the time.
Sure.
Over.
Hari Balaji, please.
Good afternoon, sir. Hari Balaji here. So, how is the psychosocial aspects of the frontliners taken care in Kerala, sir, to avoid the burnout?
Well, I must tell you that this matter was discussed, and the decision, Kerala has this psychosocial support mechanism in place. This issue was discussed, and the health secretary had reported that there is a mechanism which is in place now, wherein stressed workers are identified and certain support is provided to them. But I am not aware of the intricacies and details of it. So I can answer that in person to you after I gather that information.
Thank you, sir.
Public health is not present today in the office, so I can't answer it without knowing from him.
Thank you, sir.
Thank you,
so
sir. Sir, we have gone 20 minutes above the time. I would request now Pinaki for the vote of thanks. Pinaki ji, over to you.
Thank you, Ajay. Thank you, Dr. Shekhar, for providing us very valuable insight on Kerala's response to COVID-19. We know how busy you are as the member secretary of KSDMA during this time. We're really, really grateful for taking time out and enlightening us on various aspects of COVID response. And it is also important to note that it is the Kerala health system, Kerala's level of awareness, education, everything work together in a positive manner in fighting COVID. It is particularly enlightening to know and understand how a vibrant local self-government can help in becoming the fast responder to the crisis. So thank you very much for these wonderful insights that you have given us during the last 1 hour. It increases our knowledge and understanding of the issues and the crisis. I also wanted to thank Luigi for support and this idea of knowledge sharing from Kerala for our colleagues. I also wanted to thank Dr. Roger and Kaushik for coordinating this very important meeting. And I thank you colleagues for joining from different locations on a Saturday afternoon. Stay safe and stay healthy. Thank you very much.
Thank you, Pinaki ji. Thanks, sir, for the time. Luigi, any last words from your side and we'll close?
No, I can only echo everyone in thanking Dr. Secker for being with us. A lot of learnings and a lot of reflections. You wouldn't see this, but we have a WhatsApp group for our broad health team across India, and it is already popping with comments on learning reflections. So it means that really you helped us to think further about a number of issues, and thank for that. And also that's very personal, but thank you also not for being on PowerPoint for 1 hour. It has been absolutely refreshing after 4 months of PowerPoints to have one person talking live to us, and it managed to keep my attention non-stop. So I just wanted to add this on a side note, and thanks again. Over.
Thanks a lot, sir. Thanks a lot for your time and your patience with the checking out and checking in for better management. Thanks a lot. Thanks, colleagues, for participation. Over and out. Bye-bye.
Bye. Bye, Ajay.
Bye bye everyone.
Bye-bye.
Bye, 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 everyone.
Bye, everyone.